everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm Debbie Foreman, the Educational Programs Coordinator for MS Focus, and I'm joined today by Dr. Ben Thrower, who will be with us for the next hour answering as many of your questions as possible. Now I'm delighted to introduce him. Dr. Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. He previously served as the Medical Director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the Senior Medical Advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. When Dr. Thrower isn't dressing up as Jack Sparrow the Pirate, which I think he's going to do this year, he can be found playing with his two wonderful grandchildren, Sam and Opal, or building his barndonium, which he might very well tell you about. So I would love to turn this over to you and we can get started with the questions. Let's see here. Why don't I at least give everybody, you can hear me, Dr. Thrower, right?
Absolutely.
Okay, so let me tell everybody what they need to do for those that have not been with us before. If you'd like to ask questions, you can do that through the Q&A button in the app, which also allows you to send your question anonymously if that's something that you'd like to do. You can always ask your question live by raising your hand, and then I'll call on you. You'll have to unmute yourself and we'll go from there. And if you're using your phone alone, you can just press the star button and 9. Either case will unmute you and you can ask your question. So why don't we go from there? Let me at least ask, we got several questions through email because they weren't able to come on. So let's do this. Kelly has said she's 41 years old. She's a female from Trinidad and has had MS for 18 years. She currently walks with a cane and she's been using beta ferron as my main medication for approximately 5 years now. Her question is, she wants to start using CBD oil without the THC. Should she stop using her meds and fully switch to CBD oil only, or should she use both of them as prescribed, the meds and the CBD?
Yeah, that's a great question. So I would think of her beta ferron or beta seron as her insurance policy for the future. So that's her MS disease modifying therapy. I think most of the evidence would still argue that CBD is more in the symptomatic treatment realm. So even though there's a lot of interesting research that might suggest that CBD has anti-inflammatory effects, we've not been able to prove yet that CBD by itself changes the course of MS. So I don't think she'd want to count on the CBD as being something that would prevent relapses or progression of disability or new MRI lesions like the beta ferron did. So generally what we've seen with CBD is it tends to help with sleep, it tends to help with anxiety. Again, it might have some anti-inflammatory effects, but I would advise her to use it with, not instead of, the beta ferron.
Okay. And Katie has said, hi, Dr. Thrower. I'm now suffering badly from a neurogenic bladder with increased incontinence. Before I think about having Botox injections, is there any drugs to help that don't cause eyes/mouth, etc. dryness, as I have chronic dry eye and possibly, I cannot pronounce the syndrome, but SJOGRENS. And also she needs it to be available in the UK.
So I can't speak to what's on the formulary generally in the UK, but what she wants to do is look at a medicine like Myrbetriq, MYRBETRIQ. So most of our bladder medicines are what we call anticholinergic drugs. So your oxybutanins and Detrol type medications, and those are the drugs that are associated with a higher risk of dry mouth, constipation, dry eyes. So she's going to want to avoid those. So here in the States, we have this medicine called Myrbetriq that works through different chemical pathways. They're not the anticholinergic pathways. And so that drug is not associated with the risk of dry eyes and dry mouth and constipation. Interestingly, going back to the previous, question where someone was asking about CBD, there is some data out there to suggest that cannabinoids, so medical marijuana, may have a positive effect on urinary frequency and urgency and incontinence. So that could be a non-cholinergic way of working as well. If those things, didn't work out, then something like the Botox injections. Botox injections just help the bladder relax. They usually last for about 3 months. And the beauty is that generally the side effect risk is pretty low with Botox.
Thank you. Caroline's saying that she's had the J&J vaccine plus 3 boosters. Do you recommend taking the latest Omicron booster, or is it better to take Evashield? She has not had COVID and do not have other comorbidities such as diabetes or high blood pressure.
So generally we're offering Evashield to people with MS who are on a drug that might suppress their immune system. So like an ocrelizumab or rituximab, maybe your S1P drugs like fingolimod, those types of medications. I love Evashield. I think it's a great way of preventing COVID. So it's passive COVID antibodies that you just give you protection immediately. We're not asking your immune system to do anything. If that was an option for her, I think that's a great option. My only reservation about the new bivalent boosters is they are changing the way they look at efficacy of the boosters. So that we're now in the United States, we're applying the influenza sort of model. We're looking at neutralizing antibodies in the laboratory to get a sense of how effective we think the Omicron booster is. That's a great model for influenza because influenza has been around forever. And so we have a pretty good track record of what's going to be an effective vaccine for influenza each year. We don't have that much of a track record with Omicron. And so there are people on the FDA vaccine advisory panel who were not thrilled with the Omicron booster getting approval based upon this kind of laboratory assay. There really is not a lot of efficacy data for the Omicron booster. That said, I don't want to discourage people from getting it. I do think in certain higher risk populations that it is still worth looking at the Omicron booster. It is just an evolving science. And for her specific question, if I had the option of Evashield versus Omicron booster, I would probably lean towards Evashield if I could get it.
Interesting. Gillian would like to know, how long is it recommended to use beta-ferron? Does the drug become ineffective after long-term use?
So there's no time limit on interferons like beta-ferron. I mean, we have individuals who've been on beta-seron, the U.S. version here since 1993 when it first came out. There is a small risk with interferons of developing neutralizing antibodies. These antibodies could make the medicine less effective, but we usually see those actually early, not late. So those are something that pop up, usually in the first couple of years of being on treatment. So really, there's no time limit on the use of that medication.
Thank you. Diane's asking, can MS and arthritis interact with each other to the point where they have different levels of pain towards the patient? Another question is, she has, she says, is there a way that I can help with my memory loss due to the MS? Also, does MS and diabetes, this is all a bunch of stuff from the same, let's deal with the first one.
Yeah,
arthritis interact with each other to the point where they have different levels of pain towards the patient.
So sorting out discomfort from arthritis versus MS-related pain sometimes gets a little confusing. A lot of people with MS describe just deep aches and pains that might be related to spasticity or central neuropathic pain, and sometimes those overlap some with arthritic pain. If someone is describing something that sounds like an inflammatory arthritis, we usually do blood testing to rule out things like rheumatoid arthritis or Sjogren's or lupus, to make sure we're not dealing with two different autoimmune conditions. Once we get past that, then the question is, would they benefit from things like physical therapy? Well, a lot of times physical therapy could address MS pain or arthritic pain. So I don't think there's ever a problem with sending someone for physical therapy. You're not going to make their either condition worse. Fortunately, a lot of the medications that we use for pain management are going to cover either base. So I think the major job for the healthcare team is ruling out a separate inflammatory arthritis that might warrant some different immune therapy versus the MS. On her second question, the cognition.
Right. Is there something that can help with her memory?
Yeah, absolutely. So first of all, we want to make sure that we know what we're dealing with. And so some people who have decreased attention and concentration will say my memory is poor, when really it's not their memory. They're not storing new information to recall it later. So that person might have an underlying sleep problem, or their fatigue problem is making their memory look worse, when again, it's really an attention and concentration issue. One of the ways that we can sort out what someone's dealing with their cognition is ideally to get full-scale neuropsychological testing or cognitive testing. So that's done through a neuropsychologist. You're going to get a whole day battery of tests and really know what you're dealing with. Speech and language pathologists do work with cognition in MS. And so they can do a little bit of lighter testing. It might not be the all-day testing that a neuropsychologist would do, and help us tease out kind of what the person is dealing with. And one of the things I love about speech language pathologists is they can help with cognitive rehabilitation. So they help develop strategies for the person to kind of work smarter and not harder, and stay in their strong areas of cognition. Sometimes we use medications that help fatigue to try to indirectly help cognition. Things like Provigil, stimulant medications might indirectly help someone's memory look better. We really don't have a medication that is specifically designed for cognition. A lot of times we get questions about some of the over-the-counter remedies for cognition. You see commercials for Prevagen. We just don't have any good data, any good science. I don't see anything harmful about it, but I don't know that it would specifically help memory in MS either.
The specialist that you just mentioned, the speech and swallowing specialist, if someone that's listening doesn't have anyone accessible to them in their area, does the Shepherd Center have those kind of specialists that do virtual appointments?
So one of the silver linings of the COVID pandemic has been it's really pushed us towards doing more things like we're doing right now, more tele stuff. And there are certain types of therapy that do lend themselves better to remote visits, and that would be one of them. So I have seen our speech and language pathologists do a little bit of work remotely if that person just really can't get to a facility like ours.
Okay, good.
Yeah.
Okay, one last thing, that the last woman you addressed her 2 questions, I just wanted to finish hers. She did ask if MS and diabetes have effects on each other.
Not directly. I would say that just thinking of ways they might overlap a little bit. So if someone has a diabetic peripheral neuropathy, they're going to get numbness and tingling and burning in their feet. That numbness and tingling and burning could be very similar to what MS might cause with central neuropathic pain. When people with diabetes have hypoglycemia, a lot of times they're going to get pretty fatigued with that. Could that mimic some of the fatigue we see with MS? Maybe. But in general, I would think of those as 2 very different things. We do want to know about someone's diabetes. Sometimes we manage MS relapses with steroids. Steroids are not very kind to people with diabetes. Steroids will definitely raise your blood sugar. So in general, we try to avoid steroid medications if possible, and people with diabetes.
Thank you. Elizabeth wants to know if the Shepherd Center has had the opportunity to try out the psionic neuro sleeve.
Yeah, great question. So we were just talking about that with our physical therapist this morning. We have seen it. We have not been, we've not actually put it on anyone. One of our patients has actually purchased the unit, but they've not actually, to my knowledge, they've not quite rolled out commercially 100% yet. From what our physical therapists have seen so far, they're very excited about it. They think it will be a nice addition to the toolbox for managing foot drop in MS. Hopefully, we'll know a lot more over the next couple of months as we get our hands on more of these devices.
Okay, and Jen is asking, she said she's had a brain stem lesion last year in July, and she still has sensory issues left on the left side of her face and inside. Her gum is sore and she still has a bad taste in her mouth constantly. Just wondering what medication she should ask her general neuro to try next to reduce sensory symptoms. She already tried gabapentin, pregabalin, and Cymbalta.
I mean, she's kind of hit some of our big actors. So those would probably be the first three that we would look at also. If those haven't worked out, I would probably have her take a look at carbamazepine or oxcarbazepine. So that's going to be Tegretol or Trileptal or the brand names of those. Those are also in the anticonvulsant kind of class of drugs. And we like those for managing neuropathic pain like she's dealing with. Depending upon if it's a smaller area of involvement, I mean, you could think about like a lidocaine, swish and spit. The problem with that is it's going to numb her mouth up. She's going to trade pain for numbness and probably altered taste. And then cannabinoids, so things more in the medical marijuana realm might be useful for this type of pain.
Thank you. Kelly would like to know, can CBD oil help with fatigue?
I think maybe. So if the person has a lot of anxiety or they're having sleep issues, so CBD at bedtime can clearly make you sleep better. That could translate into better energy levels. If part of your fatigue is tied in with mood disorders like anxiety, if someone is struggling with a lot of anxiety, it's exhausting for people. If that's her situation, then I could see CBD helping. But we don't typically think of CBD as a direct fatigue medication, like say a modafinil or a stimulant drug. But it could help indirectly through those mechanisms that I mentioned.
Okay, and this is a question coming in, and we don't get this very often, but it's a great question. What do you recommend for sexual dysfunction?
So it depends upon male, female, and what type of sexual dysfunction we're talking about.
This is an anonymous person. If that person who put the question in would like to tell us whether they're female or male, you can type that in, but as of right now, I don't know.
So let's assume it's a guy. Then, I think of sexual dysfunction in men as it can be complex, just like you can in women, but a lot of times with guys, it's going to be erectile dysfunction or delayed orgasm. With the erectile dysfunction, I think of erections as being like, think of the penis as like a house. You got an electrical system and a plumbing system. And normally we think of MS as affecting the electrical system. Most of the drugs that we use for erectile dysfunction, Viagra, Cialis, Levitra, technically they work on the plumbing system, but they do work in MS, even though it's an electrical problem. So we certainly try those out to start off with. We want to look at the person's medications to make sure that we're not that the person's not on a medication that could affect sexual dysfunction. A lot of antidepressants, for instance, are associated with delayed orgasm. So we want to kind of tease out what is driving the sexual dysfunction. Is it an MS symptom that is interfering with sex? So if you have bladder symptoms, if you have spasticity and spasms that are acting up during sex, well, that's not very conducive to sex then. So sometimes we manage the sexual dysfunction by addressing the primary MS symptoms. Female sexual issues can be complex. So we want to think about, is it dyspareunia? Is it pain with sex? Is it dryness? Are we maybe, like the person was mentioning earlier, on the anticholinergic drugs for bladder? Have we dried out this person's mucous membranes, including, vaginal secretion. So is that part of what's causing the sexual dysfunction?
Excuse me, Dr. Thrower, they did answer, and she is a female, and it's regarding delayed orgasm and sometimes no sensation.
So with the delayed orgasm, I would start with looking at the medication list first. Make sure we're not on a medication. So the big offenders for medications are going to be things like Prozac and Paxil will really delay orgasm. If we need the person to be on Prozac or Paxil, one of the things that we sometimes do is add a little bit of bupropion or Wellbutrin to that. It seems to get rid of the delayed orgasm side effect of Prozac and Paxil. If there's decreased sensation, sometimes we have to find another sensory pathway. So if, say, oral sex or sexual intercourse is not enough stimulation to cause orgasm, we may need to have the person up their game a little bit. And so the use of toys, if the people are not aware of this thing called the Hitachi magic wand. My former nurse practitioner, Tracy Walker, would give whole talks on this device. So the magic wand is something you can order on Amazon. It looks a little clunky. It's about 1.5 feet long. It's not for insertion. It's just external stimulation. It plugs into the wall. It vibrates, and it can bypass some of the sensory blockades that we see with multiple sclerosis. It can be used in both men and women. But so sometimes we need to find other sensory pathways that are going to get a different form of stimulation. There are GYNs and urologists who do specialize in female sexual issues, and if we've tried out our bag of tricks and we're not getting where we need to be, then we usually get someone referred over to one of those folks.
Thank you. Great answers. Is there anything that can help with the MS hug besides medications? This person said they tried Lyrica and that did nothing. They have carbamazepine, but she's hesitant, or he's hesitant to try it because of the possible side effects. They're looking for something natural. Is there anything at all?
You could, again, in the medical marijuana realm, I consider cannabinoids to be more in the natural realm. Usually, if we're looking for pain management, CBD by itself is not going to quite cut it. Usually, we need CBD with some higher concentration of THC in it. So that would be something that the person could look at. I wouldn't be too afraid to try the carbamazepine or its cousin, the oxcarbazepine, which is trileptal. Usually the doses of those two drugs that we're using in things like the MS hug are not big doses. When someone picks up a product information sheet and they read the side effect list of carbamazepine, a lot of times those side effects apply more to the higher doses that we would use if we were treating epilepsy. The lower doses that we might use in an MS situation, generally the side effect risk is pretty low. I would say the risk of carbamazepine side effects is probably not that much different than the other things that we use, like gabapentin and Lyrica and duloxetine, those types of medications.
Tiffany wants to know, do you believe childhood trauma triggers or could cause MS?
I don't directly. So MS obviously is complicated. And so there are genetic factors and there are environmental factors. There was a huge study years ago, the North American Nurses Trial, that looked at almost 200,000 nurses in North America for a lot of different health conditions. And they would look at something like multiple sclerosis and say, okay, let's look at this person's whole life. And there just wasn't any clear correlation between psychosocial traumas and the risk of developing multiple sclerosis. Humans are interesting creatures in that we tend to tag when we have something bad happen, like developing a long-term health problem. Our brain wants a reference point in our life. And so a lot of times it will go back and say, well, I think this started when this big event happened in my life. So you hear that sometimes with different health conditions, people will say, I think this started after my divorce, after my car accident. And I'm not saying that that couldn't be true, but that is the way the human brain works sometimes, is it goes back to a traumatic reference point or a big event reference point in life. So that's a long roundabout way of saying I don't think there's good evidence to say that childhood traumas would put a person at higher risk for an autoimmune condition like MS.
Thank you. So there's someone who said that they have primary progressive MS and the current DMT that they're on, which is the only option for them, is Ocrevus, and that's FDA approved. If she or he continues to take Ocrevus, but still continues to have more lesions progression, what are your opinions or thoughts on things that they should think of or consider if they were thinking about pursuing other options such as HSCT, which I think is, I can't pronounce it, but stem cell transplantation in locations outside of the US as an option?
So I would step back and say, are we really convinced that this person has primary progressive MS? So the fact that they're developing new lesions would make me at least think, okay, are we really confident that that's the right diagnosis? It could be, but primary progressive MS usually on imaging studies like MRI is usually pretty boring. It usually doesn't change drastically, even when the person is getting worse physically. So the fact that this person says they're having new lesions would make me say, let's go back to the drawing board, make sure we're really comfortable. Do we try things that are off-label, in situations like this? Absolutely. I think everything's open for discussion. If this person truly has a progressive form of MS, the data for HSCT, hematopoietic stem cell transplantation, is not wonderful for progressive forms of MS. When you look at the really good data out of places like Northwestern in the United States, or some of the Canadian centers, or the centers in the UK, really where you saw the most benefit of HSCT was in people with relapsing forms of MS with hot disease. They had relapses, they had new lesions on MRI, and usually they were under the age of 50. I've had a lot of individuals with progressive forms of MS go to either the clinics in Mexico or to Russia, and I've not been blown away with what they've gotten out of HSCT. My experience has been that people seem to feel like they've stabilized for a while, usually 6 months to a year, and then they feel like they're progressing again. And then we're back to having the same sort of discussions that we were before.
Debbie says that spasticity is really her worst symptom, especially at night. She has tight hamstrings, but she takes baclofen at night. She just can't do that during the day because it makes her too tired. What are your thoughts on transcranial direct current stimulation? Any other recommendations? Yeah,
so I think when we think about spasticity management, just think of the pyramid model. So, and kind of the base of the pyramid, or your base therapy, is going to be stretching, and more stretching. We just want to make sure the person has really aggressive range of motion and stretching. Then we get into the oral medications, so baclofen and tizanidine. If she's hit a maximum of baclofen that she can get, so she's getting sedation, if she goes any higher, then I would want to make sure that she's looked at tizanidine. You can use those two together as well. One of the drugs we don't talk a lot about in the MS world that my colleagues across the hall at the multi-specialty clinic, where they work with more spinal cord injury, for us to remember, is dantrolene or Dantrium. It's an old oral medication for spasticity. It can help out in some individuals, and it can be used along with a baclofen or a tizanidine. Kind of next notch up is going to be things like the cannabinoids, again, the medical marijuana, which their strongest data is for spasticity and spasm management. Botox, intrathecal baclofen or baclofen pumps. And then I don't think there's anything wrong with looking at the transcranial magnetic stimulation. Where the best data for the transcranial therapies are is probably for fatigue management in MS, but it's certainly a benign thing to do, and it's not going to cause any type of significant side effects. So I would say it may be worth looking at if she's covered all of these other bases.
Thank you. Jen is asking, besides lesions, what should my yearly MRI track look for? A brain mass?
So so with MRIs, one of the things we do that we don't talk a lot about is ruling out other things. We want to make sure the person hasn't developed some other health issue, God forbid, a brain tumor or something like that. And then we would like to look at the volume and number of the white matter lesions. We would like to look at the brain volume itself, the whole brain. And then what we're learning is that, where we've focused so much on the white spots on MRI, those white spots, while they're important, they really don't tell the whole story. We need to start thinking about things like deep gray structures. So like the thalamic volume. One of the challenges that we have right now is trying to find good computer volumetric programs that help us measure these things and do it in a reliable fashion. Some of the programs that have been out there, there's been some issues with reliability, with sort of getting good data out of those machines. But we tend to want to do a spinal cord MRI periodically as well, and look for atrophy or new lesions in the spinal cord.
Kelly would like to know, can the MS hug cause shortness of breath? All her cardio and pulmonary tests are negative.
Yeah, a lot of people with MS do have a sense of shortness of breath. Sometimes it's associated with an MS hug. Some people just have it without the MS hug. They'll say, I can't get a deep breath. I feel like I'm short of breath all the time. And I think she raised an important point. You want to rule out other non-MS causes, so cardiopulmonary causes. But sometimes we go through that and then the person is left with, I'm still short of breath, and there's no cardiopulmonary reason for it. The muscle, most of what moves air in and out of our lungs is the diaphragms. But in between our ribs, the intercostal muscles do play a role in sort of helping the ribs move in and out. In some people with MS, the rib cage is not fully expanding, either due to muscle weakness or muscle tightness. If your rib cage is not fully expanding when you take a deep breath, you will get a very distinct sense of shortness of breath. If we measure your blood oxygenation, it's going to be normal. So it's the sensation without a significant physiologic complication. So that hopefully people find reassuring. Still doesn't make them feel not short of breath. And so one of the things that we have people try out, if they've gone through all the tests and there's no cardiopulmonary reason for the shortness of breath, is just get one of the incentive spirometers off of Amazon, or if they have one left over from a hospitalization. This is the plastic tube they give you in the hospital with the little plastic colored balls in it. And you breathe in really deeply. You try to keep sucking in and hold those plastic balls up as long as you can. What you're doing when you're doing that is you're really making the rib cage expand as far as it can. It's basically a stretching exercise for those muscles between the ribs to help them stretch out a little bit. It could be a strengthening exercise for those same muscles if they need strengthening.
So this particular question is something that I'd like to at least speak on just a moment before I give it to you, because they're asking, I'm going to read it to you, but they say, are there any books that you recommend reading to help us understand MS better? I am interested in learning more in depth about it as a whole, but also lesions in the brain and spine and other locations and what symptoms they can cause. Also about nutrition and how they can help, or hurt MS. So before you tell me what you want to say, I'd like this person to know that we have a multitude of booklets and books that we send to you with a postage paid envelope to return to us. We have all kinds of educational materials available to the entire MS community that all you have to do is either go online and look it up to msfocus.org, or just call us. Or even if you were to return the email that you got today and let Bhavia, who's running the technical stuff today, she'll get it and she'll send it over to me. I'd be happy to address that with this person or anybody else that wants booklets. But we have so many, we have an entire library of things that are available. You may very well know of something else, but we do have a great, great library of things that are available to everybody. So now you can answer your question.
I like your answer. So I take advantage of the stuff that's on MS Focus. And I think sometimes the nice thing about MS Focus is you can do it in bite-sized pieces. So, one day I want to learn about the epidemiology of MS, what causes MS. Now I want to learn about the use of MRI in MS. Sometimes if you try to eat the whole elephant in one bite, it's overwhelming and people's brains shut down and it's too much to try to take in. So that's one thing I would echo exactly what you said about the resources on MS Focus, including, some of the videos and programs that we've done over the years with different speakers. I will put in a shameless plug here. There is a book out called Navigating Life with MS that myself and Dr. Barbara Geiser from UCLA and Kathy Costello, who's now with Can Do MS, we put this together a few years ago. They're going to start working on a new edition. A lot of the basics of MS, things about epidemiology and symptom management, some of those things don't change as rapidly as disease-modifying therapies. The real reason we need a new version of the book is the disease-modifying therapies. We've got new stuff out there that wasn't available when we published this book 5 years ago. But I would take a look at that, at Navigating Life with MS, and then all the stuff on the MS Focus. But just take it at your own pace. Especially if this is a newly diagnosed individual, I really do think that the first year of a person's MS diagnosis can sometimes be the most challenging. You're trying to learn about MS, you're trying to learn about your medications and your diet and your therapies and what is my body doing and is this important and do I need to call my healthcare team or not? I think in some ways it gets easier after that first year of kind of adjustment.
Perfect. I wonder, do we have some of your books in our library?
I don't know. We can certainly get you some.
Yeah, we'll have to find out. We may very well have a couple. So
yeah,
or they can they go online and order that?
Yeah, it's on Amazon for sure.
Okay.
Yeah, Navigating Life with MS.
Nice. Okay. So Karen wants to know, what do you advise for Kesimpta dosing when taking the new COVID booster, i.e. skipping a dose, etc.? Also, would you advise taking Evashield after the booster?
So to answer that last part first, if you're using Evashield, you don't need to do boosters. So the Evashield really takes the place of the boosters. You're getting passive antibodies. The timing of when you get a booster and when you get your B cell therapy is a little tricky. We've got a lot of data for drugs like ocrelizumab and rituximab, and with those, we were trying as much as we can to get the vaccines and boosters at the midway point as much as you can, although in reality, I'm not sure it mattered that much because most of our patients on those B cell therapies, on ocrelizumab and rituximab, just weren't making a ton of COVID antibodies, regardless of when they did their vaccine or booster. And that's why we were doing the Evashield. I suspect that's going to apply to Kesimpta as well. I don't know that skipping a dose of Kesimpta to do your booster is going to make a huge difference in terms of your antibody response to the vaccine or booster. And you could argue, well, is there an MS risk in there by missing that dose of Kesimpta? I think we should have the Evashield discussion with our Kesimpta patients as well. If it's available to that person, we know you're going to get antibodies with Evashield regardless of when you got your dose of Kesimpta. So I would, urge this person to have that discussion with their healthcare team and see if they can access Kesimpta and maybe do that in place of the booster.
Did you say that the Evashield doesn't cover the newest variation, the Omicron?
It does cover Omicron with one little exception. So there is some data out there to suggest that Evashield may not give great coverage for an Omicron subvariant called BA 4.6. The last numbers I saw is that the BA 4.6 Omicron subvariant probably accounted for between 7 and 10% of COVID cases in the United States. So you're still getting coverage for 90% to 93% of the COVID variants that are out there.
Okay, and this question is one of those questions that I hear constantly. Are MS patients considered immunocompromised?
Yeah, that we get that one a lot too. So MS by itself, let's put the therapies aside. So if we were just talking about multiple sclerosis in its natural state, it does not immunocompromise individuals. People with MS have a relatively overactive immune system. It's overactive in that it's attacking something that it shouldn't be attacking, the myelin and the axons in the central nervous system. So people with MS generally are healthy individuals. A lot of people with MS will say, boy, before my MS diagnosis, if there was a cold, an upper respiratory infection going through my family, I was the last person to get it, if I got it at all. And it may be because their immune system was relatively revved up. If we look at the therapies, the disease-modifying therapies, then we do have the potential with some of those to immunocompromised individuals with MS. So, the B cell therapies, with a B cell therapy, we are specifically targeting a population of B cells and knocking them down. So we are potentially immunocompromising the patient. You could argue with the S1P oral therapies like our fingolimod and siponimod that we're locking up some of those white blood cells in the lymph nodes. We're not letting them get out and circulate. So we could mildly immunocompromised individual, Mavenclad and works by knocking down populations of B and T cells temporarily to letting the system reset. So you could say, well, the person might be a little immunocompromised on that type of drug.
Dr. Thrower, there's an attendee asking if you have any experience with transcranial magnetic stimulation for central neuropathic burning pain.
I do. I've had individuals receive it. We don't offer that therapy here at Shepherd Center yet. There is literature out there to support its use. I'm certainly open to it. To me, that would be a therapy that's sort of on the cutting edge. It would seem to have a fairly low risk. I can see the appeal to it, as opposed to taking an oral medication where maybe you get sedation or other side effects. So yeah, I don't have any personal experience with it, but I'm certainly open to it.
Okay, and we do have a question. It's a great question. This might be a slightly morbid question, they say, but I want some good to come from me having this evil disease. I am interested in donating my body to science when I pass away. Are there any companies or organizations that specifically look for people like me with MS that I could sign up with so I can help to find the cure when I do pass?
Yeah, not morbid at all. I think it's noble and altruistic of people to want to help their fellow man, and that's certainly one way that we can do that. Traditionally, what we've had people do is go to the Rocky Mountain MS Center website. They have a brain donation protocol in place there. I haven't checked it out recently, but that traditionally that was who was accepting tissue donations from individuals with MS who wanted to help research and help end MS.
Thank you. Jen is asking if steroids and plasmapheresis is not helping during the emergency hospital stay, what other treatment, if there's any, that can be tried to stop the attack?
So if the person has received steroids and then they got plasma exchange, there was a Mayo Clinic study years ago that said, plasma exchange seemed to help 50% of people who didn't get benefit from steroids. If the plasma exchange hasn't worked out, the only other acute relapse management really that's out there would be IV immune globulin. So that would be, and it does have a different mechanism of action from both steroids and plasma exchange. It's typically 5 days in a row of IV immune globulin. Some people might add ACTH to that list. ACTH is what we used to treat MS relapses before there were steroids. So this was standard practice in the 1960s and 1970s. I would argue that if you've not gotten benefit from steroids, the chances that ACTH is going to work is probably pretty slim. The way ACTH works is it just tells your body to make more natural steroids. Well, natural steroids and synthetic steroids, I mean, they end up doing the same thing, working at the same receptors. So I would mention ACTH, but then I would say I wouldn't be optimistic that that would be a great option. So IVIG would probably be the most reasonable thing.
And if you could explain to Stephanie this answer, be great. A recent appointment with her general neurologist said that her MRI is stable. She's had 2 new lesions and her head feels miserably different. Can you briefly explain the different appearances of lesions and what they mean, please, and thank you.
So traditional white spots, with MS. So they're real when you're looking at an MRI, there are different sequences on an MRI, depending upon how long they have that radio frequency on and the different magnetic settings. You end up with what we call T1 weighted images and T2 weighted images and something called flare images. So different spots, depending upon what type of image you're looking at, could be light or dark. So traditionally, we talk about white spots and they have a typical appearance on MRI. We talk about black holes. If a white spot is associated with a corresponding dark area on T1 weighted images, and that dark spot has been there for a long time, what we think that represents is axonal transection. It means more than the myelin has just been damaged, that the nerve fibers underneath that myelin have actually been cut, and that's what we refer to as a black hole. So if a lesion is brand spanking new, meaning 4 weeks old or younger, it's going to look super bright white on the T2 weighted images. If we give dye by vein, that lesion is going to light up with dye, because when an MS lesion is brand new, the door to the brain, the blood-brain barrier, is more open. That's the way inflammatory cells are trafficking in and causing that acute inflammation. Well, when those white blood cells go through that open door, the dye that we give by vein can also go through the open door and light up that lesion. And MS lesions will take up dye or contrast, usually for about 4 to 6 weeks from when they very first start. So yeah, there's a lot there with MS lesions in terms of how they look. It depends upon the age of the lesion and also the type of image that you're looking at on MRI.
Thank you. This attendee said that they stopped Empira for a month. Only take it once a day, they say now, because it causes urine retention. Plus, they're trying to drag the drug out since Medicare doesn't cover the original drug. Have you seen it help once a day? And are people complaining about the generics? One brand better than the other? They said their walking was terrible with increased spasticity.
So we do have people that get away with taking Empira, or the generic on that is dalfampridine, on a once-a-day basis. Whenever we have the Empira dalfampridine discussion, people should also be aware that there's the old school mom and pop pharmacy compounded version called 4-aminopyridine. 4-aminopyridine's been around way before there was dalfampridine. It is a very, very similar molecule. It's basically a slightly shorter acting version of dalfampridine. So that is available. That is not FDA approved. It's usually paid for out of pocket, but it can be magnitudes cheaper. If someone's having to pay for dalfampridine out of pocket, they may want to talk to their healthcare team about 4-aminopyridine, because it's going to be a whole lot cheaper. I haven't looked at the prices recently, but Skip's compounding pharmacist in Fort Lauderdale, Florida, was traditionally one of the bigger mail order compounding pharmacists, and usually had pretty good prices. I know for us here at Shepherd, we are a compounding pharmacy, and our 4-aminopyridine, if you were paying monthly or paying out of pocket on a monthly basis, it's about $90 a month. I think skips is cheaper than that because they're bigger volume. So yeah, it's fine to take dalfampridine on a once a day basis. It does help some people taking that way. And I would do a little bit of price shopping. I don't have a lot of experience with the different generic manufacturers of dalfampridine. I wouldn't expect that there's going to be a big difference from one generic to the next. It's a pretty simple molecule, and because of the simplicity of the molecule, I wouldn't expect a lot of manufacturing variability from one company to the next on the generics.
Okay, you said Skip's Compound Pharmacy?
In Fort Lauderdale,
Florida.
right
Good
in your
to
neighborhood.
know. Yeah, it's right in our neighborhood. Good to know.
Yeah.
Okay. Katie would like to know what could be causing her to choke on her own saliva and water recently?
So we take swallowing issues really seriously in MS. Swallowing is very complex. A lot of things have to happen in just the right sequence for swallowing to be normal. So it's not unusual for MS to throw, a little wrench into that process. So anytime someone describes swallowing issues to me, I want to get the swallowing therapist involved. And so the thing that we don't want to miss is aspiration. So some people are aware that they're choking every now and then, but what they're not aware of is they're actually aspirating on liquids, solids, or their own saliva a lot of the time. And it's just the kind of the iceberg under the surface that they're not aware of. It's not healthy. It's a risk for pneumonia over time. So the swallowing therapist is usually going to order a modified barium swallow. That's their version of an MRI. That's how they know what's going on and really be able to objectively tell us where things are not going right with that person's swallowing.
Thank you. Let's see. This person is anonymous and would like to know if hearing can be affected by MS and vice versa.
It can be, but it's not very frequent. And I'm not sure we know why that is. So you have 12 cranial nerves on each side of the brainstem. The 8th cranial nerve is the one that supplies hearing and also balance. And whereas we see a lot of balance issues and vertigo issues with MS, we don't see a ton of hearing issues. So if the person is having hearing issues, you certainly want to get an audiologist and or an ENT doc involved to see, what is there some better explanation than the person's MS. We've had a handful of individuals have autoimmune hearing issues where it's not a direct result of their MS, but it's kind of a bystander effect. So they have one autoimmune condition in MS, and now they've got second autoimmune condition. We certainly don't want to miss that because there are very specific treatments that the ENT doc would recommend for treating an autoimmune hearing problem.
We have an attendee who's long past menopause, and they're still curious as to whether there's a non-drug treatment for overreactive body temperature regulation, i.e. hypothalamus-driven hot flashes or chills.
Yeah, the thermostat being off in people with MS is enough of a problem. And then if you throw any kind of menopausal or perimenopausal, postmenopausal symptoms on top of that, it gets really, really kind of tricky. I do like for women who are dealing with temperature regulation issues to at least run it by their GYN to see, is there any sort of hormonal manipulation that might help address that if the person is comfortable going that route. We do sometimes think about this compounded drug, the 4-aminopyridine, as something that might help with temperature regulation issues. It's a little bit of a long shot, but if you think of someone's thermostat being off as being a result of demyelination somewhere like in the hypothalamus, well, the way 4-aminopyridine and dalfampridine are designed to work is they hopefully improve electrical conduction and demyelinated nerve fibers. So is it possible that you could see, some of the heat issues get better? And then kind of the bigger camp of just heat intolerance or temperature regulation issues, we certainly look at old school, cooling vests and things like that, if that's appropriate for certain situations.
Dr. Throw, we have 4 questions in a row regarding Evashield, and a couple people have never heard of it before, so they'd like an explanation. One of the 4 says, does Evashield block any antibodies you might get from the vaccination? And another person said, when should I get my second Evashield? 6 months, 8 months after my first dose, which was a full dose in April. So you might want to talk on, there's 4 of them in a row.
So Evashield is a monoclonal antibody against the COVID spike protein. So monoclonal antibodies are antibodies that are engineered in a laboratory to do something very specific. You want to prevent something, block something. So these are antibodies that were developed in a laboratory that attach to the spike protein of COVID. Evashield is technically 2 monoclonal antibodies. When you get it, you're going to get a shot in each hip. That's because there's 2 different antibodies going after the COVID spike protein. The original COVID monoclonal antibody was Regeneron. Regeneron was great against original COVID. It was really good against Delta. It didn't have very much effect against the Omicron variants. And so that's why you don't hear us talking about Regeneron much now, whereas we did in the past. Now we're talking about Evashield. I suspect if COVID sticks around longer and it mutates more, we're going to have Evashield 2.0 or something else, some other name of a different monoclonal antibody that's been adapted to hit whatever mutations COVID throws at us. The FDA authorized Evashield to be used in 2 situations. It can be used to treat acute COVID infections if you're really, really sick with COVID. And it could also be used to prevent COVID in people with certain higher risk conditions, like MS, if you're on a drug that might suppress your immune system. The FDA has authorized a repeat dose 6 months after the original dose. Kind of works nicely if you're on a drug like ocrelizumab or rituximab, because you're coming in for every 6-month dosing. So what we do is we just have the Evashield discussion when people come in for their infusion, and we offer it to them on that same day. We are not aware of any drug-drug interactions or other antibodies being blocked with Evashield. Obviously, rituximab and ocrelizumab are monoclonal antibodies, so we're giving these patients 2 different monoclonal antibodies on the same day. One as passive protection for COVID, and one as their MS therapy. So that's kind of the brief primer on Evashield. Now, right now, the FDA has only commented on doing an additional dose 6 months from the original. I would imagine they're going to go ahead and authorize that to be done on a recurrent basis. If someone isn't thrilled about doing Evashield every 6 months, we can certainly check COVID antibody levels and see. I do think Evashield lasts longer than 6 months in some people. I've had people go out to 9 months, I know for sure, and still have good antibody levels after their first dose of Evashield.
Thank you. Since we're nearing time to go, do you have an extra 3 minutes to stay with us?
Sure.
Okay, I'll see how many we can get by then, and we'll try. Our next question is from Peggy. Can you explain pseudo exacerbations and how long-term impact, if any, if there's an impact?
So pseudo relapse would be a worsening of a neurological symptom that's provoked. So it's brought on by usually an infection, UTI, upper respiratory infection, or heat exposure, or maybe some big psychosocial stressor. So it's not a true relapse. The symptoms are very real, because it's not a false symptom. The symptoms are there. It's just being provoked by something. To the best of our knowledge, there should not be long-term implications. Usually pseudo relapses resolve, within weeks after the stressor, infection, or whatever is going away.
Kelly would like to know, does relapse remitting MS always eventually progress to secondary MS?
So the natural history without treatment of relapse and remitting is that almost everyone would move towards secondary progressive MS, varying times from person to person. The hope is that with all of this armamentarium of treatments that we have now and tools in the toolbox, is that some people don't move to secondary progressive. We feel like we have enough, therapy available now that hopefully we can freeze the person's MS in place and see no progression, no relapses, and no new MRI lesions. I tell our individuals we work with, that's an A+ on your MS exam, and that's what we're shooting for, is an A+ for everybody.
Great. We have someone who's asking this question. During their hospital stay this year that eventually got them to get their MS diagnosis, they were given 5 days of IVIG treatment. They didn't improve at all. And in fact, their symptoms got a bit worse before they were actually able to see the MS specialist for the diagnosis and get a high dose of IV steroid treatment. Does IVIG help MS patients, and did it hurt me at all?
So very unlikely that it hurt anything. So every relapse management that we have, whether it's steroids, IVIG, plasma exchange, has a certain success rate. And whereas most people get benefit from one of those, not everyone does. And so there's always that individual that we throw the kitchen sink at them and their relapse still doesn't get better. But there definitely would not be any harm from IVIG. It's generally a really well tolerated drug. And in some countries, IVIG is actually used long term as a long-term disease modifying therapy. There is data out there to support its use on a monthly basis as a long-term MS treatment. The reason we don't do more of that here is it's not FDA approved, and it's a god-awful expensive treatment. And so getting insurance companies to pay for it long-term is really, really difficult.
Wow. What do you recommend for the sensation of insects crawling on them, especially when the temperature is cold?
So that's in the form of what we call a dysesthesia, or an uncomfortable extra feeling. So some of the things we've mentioned earlier that you would use for central neuropathic pain, gabapentin, pregabalin, duloxetine, oxcarbazepine, carbamazepine would all be candidates. If it's a localized area, you could even try out maybe a topical. We've done things like topical lidocaine, lidoderm patches, topical CBD would all be things if it's a very limited area of involvement.
Is there any benefit to hyperbaric chamber sessions?
There was a study in the 1950s that suggested that hyperbaric oxygen was associated with a lower risk of relapses and progression of disability. The MRI wasn't around then, so there was no MRI component. Every study since that time has not seen any benefit from it. So, if someone wants to go, if they say, I feel more energetic after hyperbaric oxygen, I don't think there's any risk to it. I would discourage someone from spending $20,000 and buying their own chamber. We have a handful of patients who have lovely hyperbaric oxygen chambers that hang laundry in their basement over them. So not great data to say it does anything in the long run.
And this is one of our last questions. Karen from Facebook would like to know, is there a best drug for MS at this time?
The best drug is whatever stops your relapses, your progression, and your new MRI lesions. In general, you can say as a class that we can make some broad generalizations. So generally, we think at the top of the food chain that ocrelizumab, rituximab, natalizumab, mavenclad, those drugs are probably at the top of the food chain. Maybe right under that would be the S1P drugs, your fingolimod, siponimod type of drugs. And then everything really kind of clusters. Your platform therapies, your copaxones and interferons and Evashield. Those are so, but it really is very, very individual. Don't fall into the trap of being in a group, maybe online or in person, where you say, well, my friend John is on this drug and they're doing great. I want to switch to that drug. I can show you individuals who do well on any of the therapies that we've talked about. If you're doing well, you're doing well. So, even you might be on one of the original therapies. If you're doing great on it, there's nothing to say you have to move to something that's newer just because it's newer.
Okay, as for Anna and Michelle, who sent in questions last, please save those for next time. They're great questions, but I think they're lengthy answers. So we'll go with the very short but really nice thank you that everyone's sending thank yous to you. But this one just touched my heart. This person who's anonymous said, I just wanted to say thank you Thank you so much for taking the time to do this Q&A. I have learned so much, and for me, it's true. The more you know is best. So very, very nice. And that brings us to the end of our time, everyone. If you've missed any part of this conference, it's been recorded and will be available through the MS Focus Facebook and our YouTube channels. Reply to your registration email for information on how to access recordings, or sign up for our newsletter to learn more about upcoming events. Our next teleconference will be this coming Thursday, October 13th at 3 o'clock in the afternoon Eastern time. And what we're going to be doing is having our staff, our very own staff at MS Focus, talk about all the free programs and services and grants that we offer, so that everybody understands what's available to them. You could easily look on our website for it, but if you'd like that up close, personal, and be able to ask questions, that's your time to do it. You'll learn all about every one of our programs that we offer. So I would suggest doing it. And let's see. As you leave the conference today, we're going to pop a survey off to you. If you would just kindly go in there for 2 seconds and fill it out. We ask that you do that so that we can really figure out what's most meaningful for you in terms of our programming. It's going to help you a lot by getting the things that you want to hear. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower for your willingness to share your time out of your busy schedule, and I know it's really busy, to educate us each month. We love the Q&As and when you do your topics. So unless you have something else to share, I'm going to bid everyone adieu. And say,
have a wonderful afternoon and evening, everyone.
Thank you, everybody. We'll see you again soon. Bye-bye.